Well, thank you to the IOF for putting on this great event. I think it's so important during this challenging time that we all stay connected and continue to learn. So today I'm going to discuss some alternatives to typical joint injections, or perhaps some adjuncts to what we're currently doing, and really focusing on osteoarthritis. So I haven't been this excited about finding new technology and collaborating with other doctors around the world than about 15 years ago when I first got introduced to PRP. And so we're going to talk about some possible new tools and this rationale for extracorporeal technology, which is basically treatments outside of the body as opposed to injections, which are internal. We're going to go over some of the existing literature on them, and then we're going to briefly highlight some of our clinical use we're doing on our patients. But when doing these talks, I always go back to this pioneering doctor in the Civil War who felt that the body can self-heal. And he said the body of man is a drugstore and has every sort of drug within him necessary to heal. And so in many cases, these orthobiologic therapies, how they're working and what we're doing is we're delivering this super physiologic milieu of cells, whether it's from plasma, marrow, adipose, or birthing tissue, to try to turn the body on and its inherent mechanisms to heal itself. So with PRP and various cell therapies, we understand the wound healing process and the growth factor and the cascade that goes along with it, from the inflammatory, the proliferation, the remodeling phase. So what if instead of sticking a needle and doing injections, are there other ways of using technology that can tap into this body's healing process? So we know that in areas of arthritic disease, for example, in a medial epicondyle that has edema is degenerated, it's not void of MSCs. In fact, they're abundant, but they're sick and they're diseased or dysfunctional. So the goal, whether it's through injections or some of these external stimuli, to turn them on and encourage healing. So when we treat the knee, we want to think the knee as a comprehensive unit or an organ. And we target the extra-articular, which is the superficial soft tissues, tendon and ligament, or the neurogenic component, the intra-articular, the synovial environment, as well as the subchondral bone. And I've done a lot of research and work on injecting intraosseous inside bone to target this aspect, but perhaps there's other ways that we can also target bone that may be less invasive. So when we look at other ways to possibly stimulate healing, obviously the number one is going to be movement and activity and exercise. Most of us that have been doing this kind of work for a while, we always want to treat an active patient, and movement is critical. But we're going to talk a bit about shockwave therapy. And shockwave has both focal and radial components that we'll talk about. I'm going to briefly highlight electromagnetic fields and laser and local cryostim. So when we look at the typical toolbox for regenerative medicine practice, we have the standard HA, exercise, PT, rehab. But then there are these intra-articular injections of PRP, BMAC, adipose, or amnio. And what else can we do to complement that process and support it? So perhaps magnetic fields, laser, and shockwave may have some future role that I think we're going to see more and more about. So when looking at the origins of shockwave, when did it come to be? It's an interesting story. During World War II, castaways and soldiers were experiencing blast trauma from remote bombs exploding in the water, would travel and cause lung damage. And so it was discovered the shock waves can be quite powerful. And the Germans in the 70s and 80s examined lithotripsy to treat kidney and ureter stones. And incidentally, during that time, they found that these patients in the region surrounding the shock wave were getting increased bone density and soft tissue healing. So this led to an explosion of research in Europe looking at other areas like skin wounds, non-union fractures, cardiac, and MSK. There's quite a bit of research when you dive in on shockwave, and really an explosion, much like orthobiologics in the last 15 years. So it's important to know there are two types of shockwave. There's radial and there's focal. Radial is more of a pressure wave, not a true shock wave, and it's used for more superficial soft tissue injuries. For example, a lateral epicondyle at the skin surface. It only penetrates a few centimeters deep. But there's some studies showing its efficacy in plantar fasciitis, epicondylitis, and Achilles tendon, but it loses its power with depth, and it lacks many randomized controlled trials. Many physiotherapists that are getting into Shockwave may start with a radial unit because it's more cost effective and is applicable for soft tissue. But the true Shockwave or focal is quite powerful. And so you're basically delivering a finite focal point of Shockwave deep into the tissue up to 12 centimeters, which is very high energy. It's ideal for targeting subchondral bone and breaking up calcifications. And there's many randomized controlled trials on focused Shockwave. So when you look at the comparison here between both, you can see both are having an explosion of research, but focal Shockwave here at the top has more publications. So it's not one versus the other. In fact, we're finding and discussing with many clinicians, as well as in this publication, that combination is superior. So this was a study looking at focal and radial Shockwave used in combination on the Achilles tendon and found that the combination, the dual use, was better than either in isolation. Next, we're going to go over some studies on subchondral bone as perhaps an alternative or an adjunct to what we're trying to do with our biologic injections. So in 2015, this is a study comparing Shockwave versus prostacyclin and IV bisphosphonate for painful knee lesions. Interesting to know, many of the NBA players in the league are receiving Fosamax, a bisphosphonate, for bone marrow edema lesions, and perhaps there's a more natural or better way to tap into the body to heal. This study looked at 40 patients and found that the Shockwave group had much greater improvement in VAS, WOMAC, SF36 at various follow-up points up to 6 months. And they found a greater reduction in the bone marrow lesion at 6 and 12 months compared to IV therapy. This next study looked at 86 patients that had 3 treatments of high energy Shockwave and found that the bone marrow edema was reduced 86% versus 41% in the typical control, which would be limiting weight-bearing activity. VAS scores improved 88% compared to 42% of control at 3 and 6 month follow-up, and WOMAC scores improved as well, superior to the control. Next, this study looked at 72 patients that also received 3 treatments of focused Shockwave, and they found that much in the literature that supports this is the size of the bone marrow edema lesion corresponds with the degree of the patient's pain, and they found significantly reduced edema and improved KOOS scores at 6 month follow-up. This next study looked at Shockwave 2 sessions weekly with IV alendronate or Fosamax versus this alendronate alone. Looked at 126 patients, Kellgren-Lawrence 1 to 3 with 12 month follow-up. It showed Shockwave was safe and was more effective in pain relief, improving function in arthritis patients with rapid normalization of MRI edema. This is a recent study from 2021 that looked at osteonecrosis of the femoral head. 67 patients had focal high energy treatment. They used fluoroscopic guidance to isolate the lesion, which can be done in some cases. And they did 3 month follow-up MRI and found decreased bone edema and improved Harris hip scores. So when we look at osteoarthritis in general, Lit Review looked at about 5,000 patients, and overall conclusion was Shockwave was beneficial for OA, but there's some variability in terms of the dosage, the technology, the energy level, and duration. Perhaps Shockwave has a role to help with avascular regions. This is a study from AJSM looking at treatment of meniscus tears and showing that the Shockwave was able to stimulate meniscal healing in the avascular region. Our colleague in Germany is using this on athletes, incidentally, anecdotally. So when you think, how does Shockwave work? What's going on here? It's a biologic tool, and it goes by this term Mechano transduction, which is basically tricking the body into mimicking exercise and loads. So it's transmitting this powerful mechanical energy through cavitation and pressure waves internally to the body. Much like when someone's jogging or running, the weight-bearing loads go up the femur into the trabeculi to strengthen bone. Integrins, which are in the cell membrane, communicate these shear forces in the cellular matrix, and cells adapt their behavior, leading to migration, proliferation, and differentiation. So there's kind of a short-term effect of Shockwave as well as a long-term. And so when you're treating a patient, Shockwave is nice in that you actually really feel it, as opposed to some other modalities like ultrasound, you can't tell if it's working. So when the probe gets right over the spot, for example, on an epicondyle, the patient will feel an intense sensation. It creates this washout effect or flooding involving substance P in the nervous system. The pain with shockwave reduction can start as soon as 2 to 5 minutes from the treatment and can last 2 to 4 weeks before the true mechanisms of healing can commence. Interestingly, when they looked at local anesthetic, if you use, for example, lidocaine to a plantar fascia or an Achilles to allow yourself to jack up the energy so the patient can tolerate a more potent effect, it had less results. And so we found that the nociceptive and proprioceptive effect of the patient feeling the discomfort and the feedback is critical to successful outcomes. This analgesic effect is so powerful that it's banned in racehorses 48 hours before races. Some more long-term mechanisms of action, as we mentioned, altered substance P and CGRP. It promotes cell permeability. It releases nitrous oxide. It increases bone metabolism. It promotes angiogenesis and osteogenesis. It releases growth factor, and it stimulates MSCs and BMP2. So, the thought is, wait a second, these are all the things we're trying to do through orthobiologic injections. Perhaps there's another way to do it or a complement to it. I'm going to go over a few studies that are a little more relevant to typical regenerative medicine practices or orthobiologic practices. This was a study looking at shockwave administration to osteoblast cultures and found that it stimulates osteogenesis or generation of bone. It enhanced type 1 collagen, IGF-1, and upregulated osteoblasts. This is a neat study on quarter horses, racehorses in the US. And they looked at 6 horses, and they took traditional PRP and they created a way to study them in a syringe-like apparatus, applied high-energy focal shockwave, and found that it was superior. And so they found that the shockwave activated platelet release and increased growth factor concentration significantly of TGF-beta and PDGF, which are critical players in PRP. So they postulated this mechanical stimulation or sudden increase or decrease in pressure alters the cell metabolism in a way to amplify the PRP. And so this supports potential use or further studies of combination of shockwave and PRP, which are traditionally used in an individual in horses. So this was a neat study showing if you shockwave an abdomen before a lipo harvest, you might be able to get higher MSCs. So they found significantly higher expression of MSCs and vascular markers, including IGF-1 and increased cellular ATP. This is a neat study looking at the effects of hyaluronic acid, PRP, and shockwave and how they share things in common. And so they found that all 3 promote regeneration and reduce chondrocyte degeneration. Interestingly, shockwave increased CD44 expression, enhancing susceptibility to HA treatment. So shockwave can potentially pre-treat a joint before receiving HA to boost HA receptors. And we know one of the mechanisms of action of PRP is through increasing the body's endogenous production or their own production of hyaluronic acid. This is a cardiovascular study that looked at focused shockwave activating stem cells, induces angiogenesis, and improves blood perfusion through this mechanism we talked about of Mechano transduction. This is a study used on rats that looked at low energy shockwave where they preconditioned ischemic and non-ischemic limbs and found that shockwave boosts endothelial progenitor cells. So when we think what's new and what's coming around the corner building, there's many innovations and tools I believe we're going to keep seeing with some really progressive technology to try to stimulate bone, cell metabolism. So in addition to mechanotransduction that we discussed briefly, there's magnetotransduction, which is using electromagnetic fields to also tap into the body's inherent ability to self-heal on a cellular level. So this is a new technique or new technology, uses high-frequency magnetic pulse. Some of you may be familiar with PEMF or pulse electromagnetic fields, which is similar but quite different. PEMF has some beneficial literature showing it can strengthen bone as well as protect cartilage. But this new technology using electromagnetic fields with higher oscillation frequencies leads to 40% more potency. So this has potential for bone and many other areas that we'll discuss briefly. It penetrates up to 18 centimeters. And the beauty of it, it can be a passive treatment. So unlike shockwave and some other modalities, the patient can have their clothes on and just simply you put a device over them passively for 15 to 20 minutes. This has been used in combination with focal shockwave, and I'll discuss some of the literature. It's approved in Europe and pending FDA approval in the US. So why use this EMTT? Well, it has very strong anti-inflammatory properties, whether there's a patient who may have an acute flare-up from an epicondyle procedure or an athlete with an acute injury who needs to get back to return to play. It represents a potential game changer for osteoarthritis. And it can also have applications for neuropathic pain. And so patients don't feel it as much as they will a shockwave, but this is just a demonstration taking paper clips and showing the power of the magnet here. So our colleague Carsten Knobloch, who's located in Germany, has been really kind to share a lot of his knowledge and some of his slides with me to share with you. This is a case of him treating a soccer player from Germany with a bone edema lesion of the talus here. So this is new technology. In fact, the Europeans have only had their hands on it for about 6 months now, but there already are a short list of studies that have come out and will continue to be published. And so there's studies on low back pain. There's a study comparing rotator cuff tendinosis with focal shockwave versus combination of EMTT plus focal that found a synergistic or added effect with greater results in this randomized controlled trial. There's publications on Achilles tendinosis with this, osteitis pubis, as well as some presentations on bone marrow edema. Dr. Knobloch has 2 recent case study presentations showing positive effects on very challenging non-union cases of the scaphoid and metacarpal. So how has this affected our practice? Since the light kind of went on for me and I started seeing these incredible results and patients really keen on alternatives to injection. Some perhaps may have a gluteal tendinosis and they're not quite, maybe it's 8 weeks and they're in this gap where PT hasn't helped, they're not quite ready for injections. Some of these modalities can be of benefit, or we have a patient who may be looking to do everything they possibly can, or a pro athlete that needs to accelerate the healing time, get some pain reduction to allow them to rehab faster. We've been doing more and more of these modalities. We got so busy doing this that we converted our traditional fluoro suite or pain suite that you see here to the left, and we've sold the equipment and we transitioned into this high-tech treatment room, basically, that has a variety of modalities we'll discuss. So patients in this COVID era, we find they like treatments that are quick, they're safe, they have minimal downtime, minimal risk, and they're natural base. So it's a natural complement along with biologic injections. It's self-pay, it's not recognized by any insurance. And what we're doing is we're tracking our outcomes. So we'll be able to eventually present and publish patients that may have had PRP plus Shockwave or some of these electromagnetic transduction therapies versus PRP alone, and be able to tease out, is this having a greater outcome or greater return to activity? So we're using high-powered laser in our practice with a local cryo stimulation therapy. We're also combining in the same treatment focal and radial shockwave, and we're going to be introducing oscillating electric fields very shortly. So this is just a demonstration here showing the local cryo, which is minus 270 degrees Fahrenheit, has an anti-inflammatory effect and can improve perfusion. And the laser also has similar effects. And the cryo allows the laser, which is quite hot, to be tolerated at very high doses. This is a radial shockwave being demonstrated, again, ideal for superficial soft tissue areas, and then followed up by focal at a more local area, as you see on your screen to the right, which is going to be more intense and localized therapy. So if you have any questions on these treatments, I know it's all new information, feel free to message me at drsampson@orthohealing.com. A special thank you to Helen Howe, who's an osteopathic therapist in Edinburgh, Scotland, who's been really helpful in sharing all her experiences and research with me. And a special thank you to Carsten Knobloch, who's in Germany, who has shared his slides, some of them graciously with me, and has been really supportive. I encourage you all to check out the ISMST conference in Vienna, Austria. I'll be presenting there on intraosseous injections, as well as shockwave to subchondral bone. It's a great forum with thought leaders. And lastly, I encourage you to tune in to our TOBY conference, which will be virtual this summer. There will be lectures from thought leaders in biologics. It's a great way to stay connected, and we will feature more technology and evidence-based research on some of these modalities, including shockwave therapy and electromagnetic transduction. So thank you very much for the opportunity, and stay well and be safe, and see you soon.